Thanks for watching. And with me is Dr. Kavuma. Dr. Kavuma, welcome.
Thank you so much, Vivian, for the introduction. My name is Kavuma Awusi. I'm a medical physicist. I'm a principal medical physicist at the Uganda Cancer Institute Radiotherapy Department. As Uganda Cancer Institute, we started hyperfractionations because of circumstances. It was around 2012 when we started thinking of hyperfractionations, because at that time there was a crisis in the department. We had one linear accelerator, we had one machine, actually by that time it was a Cobalt, and the number of patients were so many. And one of the easiest way which we found to increase on the number of patients we can treat is by giving bigger fractionations of radiotherapy, which helps to reduce the duration by which the patient is treated. So we started this idea of hyperfractionation in 2012 in our department. And we did it for several types of cancers, including cervical cancer, breast cancer, prostate. All of these were among the first type of cancers which we treated with the hyperfractionation. And actually recently, about 2 years, about 2 years ago, even made a 5-year analysis of how our patients were favoring. That's where we are comparing the conventional or the standard fractionation regimen with the hyperfractionated regimen. And we assess the patients in terms of survival, in terms of toxicity, and the outcome.
With that kind of introduction, what did the report show, and what have been the next steps, or what were the next steps after making that kind of research and analysis?
Well, the report, one of the limitations of that report, because it was a retrospective study, by that time we are doing it randomly, and because we are in a crisis. So right now we are doing a prospective randomized study where we are recruiting patients for the conventional fractionations and the hyperfractionation. And this study has been going on from January this year. We are targeting to recruit up to 200 cervical cancer patients. Then we will do the analysis. We expect this study to continue up to around June next year. Right now, we have recruited about 100 patients in the study, and we are still following them up. So the retrospective study, we didn't see a significant difference between the conventional and the hyperfractionation in terms of survival. There was a difference. The only difference was mainly those which were HIV positive, because the number of HIV positive patients among the cervical cancer patients is also quite huge. As you may be aware, cervical cancer is assumed to be an HIV-related illness. We find that almost 35% of patients with cervical cancer, they are also HIV positive, which is the status which is totally different in any other. If you are to analyze any other groups of women, you find that HIV incidence is much, much less compared to that which you find in cervical cancer patients. For example, in the general public, the percentage is about 7%, but when you come to cervical cancer patients, the number of patients who are HIV positive are quite high. Here in the study, we discovered that those which are HIV positive, their survival rates were relatively lower compared to those who were HIV negative.
So, what is being done to improve survival rates?
Probably we should try to answer why are survival rates poor.
Okay.
The biggest problem why our survival rates are quite poor compared to other countries is most of our patients, almost 80% of our patients, present with locally advanced cervical cancer patients. Cervical and all cancers, chances of cure is mainly dependent on the stage of the disease. So most of the patients, because there's no screening, by the time they come, they are already in stage 2B up to stage 3B. Actually, majority of our patients are stage 2B to 3B, which is relatively advanced. So the even if you are in a very good center, patients with very advanced stage, chances of survival is relatively minimum. So for us, if you combine the patients present with the advanced diseases, plus also the limitations in terms of equipment, the patient again are going to wait for much longer before they start the treatment. So all of these makes the reasons why probably their survival rates are relatively lower compared to other developed countries.
And what are some of the interventions that are in place to improve survival rates, maybe?
Well, I don't think as a government there has been a lot. Of course, all of these, whatever they are trying to do to increase awareness, to inform people that once you see these symptoms, go to the health facilities. And the easiest or the most practical thing would be to make the diagnosis as early as possible, such that if the diagnosis has been made as early as possible, appropriate treatment is done, there the chances of survival also will automatically increase. So at the moment, even with the UCI in their camps where they go, they tell these patients the symptoms which they should look for in case they see these symptoms. They rush quickly to health facilities where probably diagnosis can be made. And if diagnosis can be made as early as possible, chances of survival and even cure is really high.
In terms of raising awareness, is it easy do people consume like posters better than videos? What format is the best?
Well, they have some videos, they have posters, but also because people have come convert, usually these health facilities, they call people to come around. So they are those people who can talk to them. Okay. And usually what UCI does also, if they are going to a certain area, they get some people or nurses who speak that language or medical personnel who can speak that language, such that they can also communicate to these people in their local native languages.
And do you work closely with HIV screening centers? Because the testing and screening centers usually, if there is a big correlation between HIV patients and cervical cancer, that would be a great place to, a high risk people, women for cervical cancers. Do you work collaboratively with
them? As you know, Oroba, HIV screening is not is by consent. So people have consent usually. So their target is not screening for HIV. Their target is screening for cervical cancer and breast. And if we start management, once the patient comes here for management, as mandatory, you screen, you test, they start doing all of the other tests. That's when we discovered that, well, this one, as much as it has cervical cancer, she is also HIV positive. But while they are there, they don't screen them for HIV.
Yeah, got it. No,
so HIV is detected as a mandate, but there are some patients who already know that they know their HIV status, and some of them are already on ARVs, but they don't know their cervical cancer status. So. Right.
I guess what I meant was, for example, if we have HIV screening centers in Uganda, like, can we work with them and say, okay, when your patients come, can we offer them opportunities to screen for cervical cancer? Because, studies have shown from, our experience that HIV patients are more likely to have cervical cancer at least among women.
I think that could be a very good idea. I don't know how far they are. I don't know whether these designated centers like Maldemay Because you know there are some designated HIV centers like
Right.
mild Uganda cares. I don't know where they are doing that screening. I need to inquire. But yes, I think it's something that can be helpful because we know that HIV, if somebody is on RV who is HIV positive, chances are high that they can do what? They can develop cervical cancer. So if in such facilities, if somebody comes there to start screening for cervical cancer, or to do mandatory, eh?
Yeah.
Whenever they come for the ARVs, maybe after 3 years, they are also done a cervical cancer screening. I think that can also be helpful. Though what I am not sure is where these centers like Mild May or Uganda Cares, AIDS Information Center, TASO, there are so many. I don't know where they are having such facilities, such type of screening exercise. But definitely it would be a good idea.
Right. And especially since I think Uganda is one of the great case studies of countries that have put in place tracking mechanisms or for HIV. They have good comprehensive systems for screening, testing, treatment, and all that. So it's a system that can be, we can get best practices from it. But with that said, back to Hypo, Hypo Africa. I mentioned Hypo Africa clinical trials. It's not necessarily part of what what you did before, but it's a new program you are a part of with other countries. Could you briefly explain what it is and why the Uganda Cancer Institute participated in it?
Okay. The primary objective of Hypo Africa is to increase access to radiotherapy to as many people as possible. That's the primary objective. And they want to do this by making sure that those few patients who have come for radiotherapy, they take the shortest time possible at the facilities. So the idea is to give bigger doses of radiotherapy for a shorter duration. So in Uganda, we have joined this group. There are two studies where we are part of them. The primary one was the prostate, which they have started with, on which we are also going to start recruiting cancer patients for that study. We also have other areas where we are thinking of patterning in breast cancer. There's a treatment regimen which we want to start as a where UCI is also part of that group. There are other countries whom we are partnering with. There's Tanzania, our neighboring, there's Nigeria and South Africa. There are several other countries also, but those are among the major ones who are part of this Hypo Africa, who have been involved in the prostate to start with, but also now we are moving into the breast Hypo Africa. And the primary objective is to increase access to as many patients as possible by giving bigger doses. When you give bigger doses, the treatment is going to be completed in a short period of time, such that you can treat several other patients with the limited resources available.
I look forward to maybe back. Oh, we're echo. To coming back to you maybe a year or so after you've implemented that to just discuss what the outcomes are, whether that helps or not. Just kind of doing an assessment. So I'm excited.
Yes, you're welcome, please.
Yeah, but in the meantime, no, thank you for again everything that maybe one last thing before I wrap up. What are some of the best practices you've picked from that collaboration with other countries? What have you observed and that is good for just Uganda?
Of course, the collaboration is beneficial because it increases the opportunity to get funding. Usually funding for such projects is quite difficult when you are a single entity. But right now, when you are many like that, you are collaborating with people who are already highly experienced in terms of research. So these people, they act as mentors. So people in developed countries benefit that these people are giving us the mentorship, which is very good for research and also for clinical work. I think that's one of the primary aim that we are gain, which we have gained. That we are good. We are getting good. The collaboration is ideal for clinical purposes and also the research itself. You do, what's the right word? I'm looking for the right word to use. The standard of research which you are going to get, which you are going to do when you are collaborating with high tech centers or these high tech centers is quite difficult to achieve when you are working alone in our centers.
All right. And
For example, if I see the level of data analysis which they can do, probably in such situation, our situation, we don't have even such capabilities.
That's great to hear. But I also wanted to point out that it's not, you're also providing something for the developed world, because you're giving data points that maybe the developed world does not have.
Yes,
So
yes. Probably the other thing which in that regard which I can mention, for example, if the study you are targeting, like for the prostate is targeting about nearly 200 patients. So if it was conducted maybe in one center, they may take longer to get all of these patients. But if you are doing it jointly with some other center, you can easily raise the total number required for statistical purposes.
there we go. So it's a win-win situation.
Yeah.
No, but thank you again, Dr. Kavuma. I really appreciate your time to speak with me and the work that you are doing to advance cancer treatment research, not only in Uganda, in Africa, and in the world. So, thank you so much.
It's a pleasure also, and please feel free to get back to us for anything you feel like you want, anything or any more information, please let us know. Even if you want to interview maybe radiation oncologists, still I can ask maybe Dr. Solomon can be available such that you combine the
Absolutely. No,
more information.
Yeah. I'm going to be at your door because Uganda is home. I want to do whatever I can to study ways of, making, improving the systems in Uganda to make them more efficient. So
you are always welcome. And as they say, East and West, home is always the best. You're always welcome.
Thank you. And before we leave, I just wanted to say to our viewers, I hope you're learning more about what's happening in Uganda, the interventions and efforts being put in place to improve access to cancer treatment, care, research. And I hope you can find ways to partner with our amazing teams that are doing a lot of work. But for now, thank you for watching. Till next time.